Buenas tardes. Gracias to the organizers for inviting me. It's a real honor to be speaking at the World Congress of Internal Medicine in Punta Cana. I want to talk to you about one of my favorite subjects, preventing kidney stones. And the question is, why should internists be interested in this particular problem? Well, there's a lot of it about. 1 in 11 people over a lifetime have a kidney stone, and that frequency is increasing. The peak incidence is in the age of 20 to 30 years, so young people. And as people don't die from kidney stones, once you have it for a long time, and there's a 50% recurrence rate up to 10 years and 75% over 20 years. So it's something we need to do something about. Kidney stones have a variable incidence globally, anywhere from 4 to 10%. And this is due to geography, genetics, diet, and now we know even the gut and urine microbiomes play a role. And of course, how often is it recognized and reported? The genetic predisposition is important. You have a 3 to 16-fold risk if you have a family member. People who have metabolic syndrome, more than 4 trays, have double the risk of having a kidney stone. And now we know that climate change, as it's making these stone belt areas, which are the hotter, drier areas, are now moving in different directions. We're going to see more kidney stones, even in places that didn't have as much in the past. What's the problem? If people don't die, they have a horrible morbidity. They have pain, absenteeism from work, and need for surgical removal. And they never want to have another one. But kidney stone disease is more than just having a stone. It's linked to other metabolic disorders. There's an increase of chronic kidney disease in those who've had a stone, or who have recurrent stones, and even coronary artery disease in women. And of course, to bone disease and metabolic syndrome, as I mentioned. And it's very, very costly, probably in the US, more than $10 billion a year, mostly linked to the surgical issues associated with stones. Whereas the medical costs are not so high, and it's been suggested that you can actually save money by preventing kidney stones, and we can't do that very much in any kind of disease these days. What are the stones made of? Well, 70% have calcium, usually as oxalate and or phosphate. You can see on this pie chart that less than 10% have uric acid stones. The struvite are the staghorn calculi, and there are some other smaller groups that have genetic disorders. Where do the stones form? Well, they actually form in the thin limb of the loop of Henle, because that's where everything's getting concentrated. All the fluid and urine, and so calcium phosphate crystals form, then deposit on that a calcium oxalate, and leading to the stones that then can extrude into the collecting ducts. Sometimes they might form in the collecting ducts de novo. But how do they form is more important if we want to know how to stop them. And they form because there's a supersaturation in a solution of the stone-forming elements that then turns into a nidus, a clinical nucleus, makes a crystal. The crystal then grows, adheres, and aggregates to form the stone. Often you need a seed, and I mentioned a few of the things that can set that off. But the real issue is this supersaturated solution. And that's influenced, obviously, by concentration, pH, and inhibitors. Concentration, simple, solutes, too much of them. Solvent, too little. Not enough fluid, and too much of the solute. What solute? Well, there's calcium, oxalate, phosphate, or uric acid. And sometimes, as I said, in combination. 50% of stone formers actually have a high amount of calcium in their urine. And that's often due to diet that's high in protein, that makes you put more calcium, lose it from the bone, and get it in the urine, or a diet high in sodium that increases calcium in the urine. Of course, it can come from too much calcium in the blood, from diseases like hyperparathyroidism, malignancy, steroids, or sarcoidosis, and too much gut absorption, which usually comes from excessive vitamin D, not the normal amount, and calcium supplements, which we don't really need. And then there are a couple of other problems. What about oxalate? Well, we think about oxalate as coming from our diet. It gets into the gut. It's actually bound with calcium in the gut and comes out in the stool, the part that isn't absorbed. But the part that is absorbed then comes out in the urine. It's also made in the liver, and there are some enzyme deficiencies. Interestingly, though, in terms of gut microbiome, there are oxalobacter in the gut that cause secretion of oxalate into the gut, and then the oxalobacter actually metabolize it. So that's a good thing. However, if we think about what we can do, we always think about diet, and there are this list of high oxalate foods, which are really the kind of foods that we want everybody to eat. So what can we do about that? And is it really a problem? This was a person, I hope you can see the little box there. In the middle of the box, there's some orangey colored numbers, 161, 223. These are oxalate levels in the urine, so high we thought this person may have primary hyperoxaluria. But it turned out she'd given up eating dairy and started drinking almond milk and eating lots of nuts and a vegetarian diet, all good, but too much. And so when that was stopped, the values went back to normal. But a bigger problem in terms of hyperoxaluria comes from the malabsorption of fat. Because, as I mentioned, calcium combines with oxalate in the gut and comes out in the stool. But if you have a lot of excess fat there, that combines with the calcium. The oxalate is left to then be absorbed. And conditions like short bowel syndrome, inflammatory bowel disease, and of course, some of the bariatric surgeries, especially Roux-en-Y, cause fat malabsorption, and this causes a big problem in calcium oxalate stones. Now, it seems counterintuitive, but a low calcium diet actually increases the amount of calcium oxalate stones. One of the reasons is if you look at this graph, it's hard to see it all, but you can just see the part going up. This is dietary calcium on the bottom against oxalate absorption going up. And you can see if you drop your dietary calcium below about 1 gram, you absorb a whole lot more oxalate. Then there are people who take too much vitamin C, which turns into glycoxylic acid, so we want to check on that, and a few other problems with hyperoxaluria. Now, so if we have too much of the things that form the stones, what about the metabolic milieu? And pH is really important. pH too high or too low. The urine pH affects different forms of stones differently. Uric acid stones form in an acid urine, as you can see from this graph, which shows supersaturation on the vertical axis against urine pH. And so uric acid stones form as the pH goes down, whereas calcium phosphate stones form as the pH goes up. Calcium oxalate stones are less affected by pH, but still an acid pH can increase crystallization. So it's important to know the urine pH. Factors that affect the urine pH are diet, medications, infection, and some tubular defects, and of course the metabolic syndrome, which affects insulin-resistant ammonia production and a low urine pH. Some people just have a lower pH in the morning, and there's some diurnal variation. But the dietary factors are interesting, because if you have a diet that has a high acid load, like hard cheeses and meats and some eggs and grains, then you'll have a lower urine pH. And it's not that any of these are bad, but too much is bad. Fruits and vegetables, you have a higher urine pH. Now, The other factor that affects supersaturation, apart from concentration and pH, is what we call inhibitors. If you look at this picture here, you don't have to dwell on it. This is a whole lot of calcium oxalate put in some water. And if you look at the steep slope, that's crystallization that takes place over an hour. Whereas if that same amount of calcium oxalate was put in urine, you can see the slope is very, very much lower. So there's stuff in the urine that stops crystallization from occurring. And there's lots of different ones. I won't talk about them. I just want to measure the one that we know most about, we can measure, and we may be able to manipulate, and that's citrate. And citrate's a powerful inhibitor because it complexes calcium. Now, there's a lot of misfacts about citrate, so I wanted to just clarify a few for you. Citrate comes from our diet, fruits and vegetables, but it also comes from the TCA cycle. Remember, it's called the citric acid cycle. And the citrate in the blood is filtered, goes through the kidney, and then, like most things, is reabsorbed. And it's reabsorbed in the proximal tubule, and that is increased if you have a systemic acidosis. But the citrate that gets in the urine, about 2 millimoles a day, doesn't actually alkalinize the urine. So it's useful in getting rid of base. If you give somebody citrate, on the other hand, as citric acid, that doesn't alkalinize the urine. But if you give it as sodium or potassium citrate, that does, because that citrate's metabolized into bicarbonate in the liver, and that causes the alkalinization of the urine. These are very important findings because we can use it to our advantage, but they also can cause some hazards as well. Move on here. The other thing about citrate is that a lot of people who have stones have low citrate levels. Some because they have a problem with acidification and or an acidosis from diarrhea, or a low potassium, which makes the acidosis in the cell worse, and they actually keep reabsorbing the citrate they filter. So this is something we have to watch for. Now, we have somebody who's got stones. We want to do something about it. What should we do? The most important thing is to examine the stone. If you can get them to pass it, send it off, because that tells us where we want to focus our treatment attention. The other things we want to know about is their family history. Do they have obstruction or infection, which of course can cause the struvite stones? Are they losing base or having bowel diseases? We want to know what medicines they're taking. Too much calcium, too much vitamin D or vitamin C. And then there's crystalluria from a number of other drugs that are commonly used. The important thing we're seeing now is more people taking topiramate, which is an anti-migraine drug, and it actually causes a renal tubular acidosis, just like one of the inherited conditions, and people get calcium phosphate stones. The diet is really critical. Sodium, protein, fruits and vegetables, and these other things, which I'm going to talk a bit more about. We do a few blood tests. It's not rocket science. I want to know how much calcium there is, maybe PTH or vitamin D. But the most useful thing is a 24-hour urine excretion, because then we can look at stone-forming factors, inhibitors, and dietary factors. And if we get a picture like this, it looks a bit confusing, but this is 4 urines over time. The bottom one is the earliest and the top one is the most recent. And we can look at changes over time. We can look to see if the urine collection was the same each time. The creatinine should be about the same. We can look at how much stone elements are in there, calcium and oxalate. We can look at the urine protein, the urine urea nitrogen as an estimate of dietary protein and sodium, of course. And we can look at all the supersaturations, which correlate best with the kind of stones. So here is a person who had passed many calcium stones, strong family history, and he was told he should take less calcium in his diet because when they looked at his urine, in these red boxes here, you can see the calcium was really, really high. Red means high in this. And so he was told not to eat calcium. What's the evidence basis for that? Well, there is no evidence basis for that. There's a few important studies that have done many years ago. One on fluids. Drinking more fluids really reduces stone. Important study. The same group then looked at diets that were low in calcium, compared those with low in sodium and protein, and showed it was the diet low in sodium and protein that reduced calcium and oxalate and the stones, not the low calcium diet. In fact, that increased them. So we know that's not the way to go. So I won't explain why all this works, except to mention, as I did before, that too much sodium in the urine drags more calcium with it. Too much dietary protein gives you more acid. That changes urine calcium and urine pH. And these are things we have to take care about. And dietary calcium, if you don't have enough, will increase your oxalate absorption. So what was happened here? If you look here, you can see the urea nitrogen went down, and so did his sodium go down in the protein, and his calcium went down too, just by some dietary changes. Here is a man who had calcium oxalate stones. You can see it in the crystals. And his findings were low volume, low calcium, high oxalate, and a bit of not too much citrate. So what should you do about him? You've got to give him more fluid, at least 2 to 3 liters a day, and give him back some dietary calcium to reduce the oxalate. And then he needs some citrate. How do you give people citrate? Well, we give the citrate as base supplements, potassium citrate, which people hate, but now there's a lot of other forms, even lemon juice, and some of these other forms that powders that you can put in water that people tolerate better. So that's what we've got to go after. And these things do work. I won't discuss this. These are the trials that have showed that they do increase citrate. These fluids, these citrus fluids, and here's a graph of them all. The ones on the left are the lemon juice, and it goes down. You can look at these. And there, 4 ounces of lemon juice here is about the same citrate as giving potassium citrate, about 40 millimoles a day. So it can work. Of course, you can use the DASH diet. That has also been shown in controlled trials to be beneficial to reduce stones, and in another study to reduce calcium oxalate compared to a low oxalate diet. What happens if you try diet and it doesn't work? Then we have to go to some drugs. The thiazides in controlled trials have been shown to reduce stones, hypercalciuria, and so our dietary citrate. Again, the studies are there for us to see. Here's just a third person I wanted to mention, a person with metabolic syndrome. You can see their weight is 100 kilos, and if you look at their, go back here, not to worry. If you look at their uric acid, it wasn't real high, but their pH was very low. And so the issue here is trying to get the pH back with potassium. You can't get the pH down very well, but we wanted to get more citrate into them with potassium citrate and try to get the urine a bit more alkaline, so as to get the pH above 6.5. I won't talk about this one because I'm running out of time here. But this was a man with calcium phosphate stones who had renal tubular acidosis. Again, we have to correct the acidosis first. So in summary, for all stones, we've got to give people more fluids. They need to drink it not just during the day, but in the evening. So when they get up in the morning, their urine will be dilute. Because that's when stones form, when the urine's concentrated, and that's what people don't want to do. For calcium oxalate, normalize the calcium intake. For phosphate, you almost have to use thiazides. Uric acid, you must alkalinize the urine, but also allopurinol is useful if you have gout or high uric acid in the urine. And we do have evidence for this in these studies that have been shown. But it's not much, is it? Just thiazide, citrates, and allopurinol for drugs, and fluid and soft drinks for diet in terms of the randomized trial, and of course the DASH diet. So that's our summary again. What else should you do? Well, my last plea to you is monitor what's going on with your patients, so that you can show a picture like this to them, which will tell the patients what's happened to them and how they've been able to make changes or where they haven't. And they can then support your efforts in stopping them getting another kidney stone. Thank you very much.